Hey guys, this is Shalom Schlagman. I'm looking forward to meeting you in person soon, but before then, I thought it would be good to give you a little background information on social determinants of health. As always, I have learning objectives for you today. By the end of this video, you should understand that social determinants of health, such as socioeconomic status and educational attainment, correlate with health outcomes. You should also consider social justice interventions as a tool for biopsychosocial care for patients with disparities in access to services or necessities. Obviously, as you of our medical students, we are taught that patient care involves addressing biological processes of disease in concert with caring for a constellation of psychological and social actors impacting both the experience and progress of illness. In this video, we look closely at the social factors impacting our patients. Since the 1970s, the impact of socioeconomics on health outcomes has been studied. Sir Michael Marmot and his group took a look at the impact of employment status on the risk of death from cardiovascular disease. They followed 17,530 male civil servants for most of the 1970s and published their study in 1978, analyzing the relative risk of cardiovascular disease-related death according to job type. They found that if they used the highest-ranking employment category, the administrator, or the boss, as the control, there was a clinically and statistically significant increase in the risk of cardiovascular death to those with lower-ranking jobs. In fact, the executives, in other words, middle managers, had twice the risk of the administrators. Clerical workers, in other words, secretarial staff, had 3 times the risk of cardiovascular death. All other workers, including janitors, mechanics, food service workers, etc., had quadruple the risk of cardiovascular-related death in the 7.5-year period of the study. Now, those of you who are looking at this graph carefully will say, now wait just 1 second. Clearly, other risk factors for cardiovascular disease associate with socioeconomic status. You would of course be correct. The rates of smoking and high blood pressure, both known risk factors, also increase as socioeconomic status goes down. Even so, the group found that most of the difference could not be explained by factors such as smoking or blood pressure. Thus, the white aspects of the bars in the figure show the relative risk of cardiovascular disease-related death when excluding known lifestyle factors. It isn't only employment status that makes a difference. A group in South Korea found a similar impact on all-cause mortality rate when separating citizens in their country by educational attainment. Now, you might say, well, there is certainly no proof that social factors impact health outcomes in the United States. How could that possibly be true? Nancy Adler and Judith Stewart of the MacArthur Foundation found that the nature of the U.S. ladder is such that the risk of dying before the age of 65 is more than 3 times greater for those at the bottom than for those at the top. Yes, you heard correctly. The likelihood that a poor American will die before the age of 65 is at least 3 times bigger than that of a wealthy American. How can socioeconomic status have such a drastic impact on health outcomes? Lower socioeconomic status can affect access to housing, food, education, transportation, medical insurance, as well as freedom from violence and hazards at home, school, or at work. Perhaps Paul Farmer says it the strongest when he says that poverty is the modern equivalent of a plague in terms of its impact on health outcomes. Of course, poverty and its attendant disparities is but one of many social determinants of health that include ethnicity, gender, sexual orientation, immigration, and refugee status, among other social factors. Well, now that we have gotten a little taste of the epidemiologic research and have a better understanding of the social determinants of health, You can understand why the World Health Organization made addressing social determinants of health a priority as of this report on screen made in 2008. Of course, now as U of R medical students, we have to ask ourselves, what does this mean to us as members of the broader Rochester community? Beautiful Rochester. Beautiful Rochester. When we look at the 75 largest cities in this country, and then rank them according to poverty rate, Rochester comes out at number 5 with a 32.9% poverty rate. When looking at cities that have a similar size to Rochester, Rochester has the worst extreme poverty rate. That means that we have the most people living below 50% of the federal poverty line of any city with a similar number of total residents. Not only is the poverty rate high in Rochester, but that poverty is often concentrated within the city. In fact, several neighborhoods in Rochester have 50% or even more than 60% of their residents living below the federal poverty line. Some of these neighborhoods are not too far from where you live. The University of Rochester is right here. The poverty in this city particularly impacts its children. While the overall poverty rate is 33%, the child poverty rate as of 2013 was 46%, which was more than twice the nationwide rate of 20%. The Rochester Area Community Foundation released a new report this year that found that the national childhood poverty rate has risen to 22%, while the city of Rochester's childhood poverty rate has risen to 50.1%. That means that 1 in 2 children in this city faces poverty. We've learned about social determinants of health and hopefully brought them close to home. So the next question is, how do we as future physicians address this important aspect of patient health? Perhaps Derek Zoolander can give us one answer when it comes to education and housing.
What Maury said I was willing to do for you. Let's get back to the reason that we're really here. Without much further ado, I give you the Derek Zoolander Center for Kids Who Can't Read Good.
What is this?
A center for ants? What?
How can we be expected to teach children to learn how to read if they can't even fit inside the building?
Derek, it's just a
I don't want to hear your excuses. The center has to be at least 3 times bigger than this.
He's absolutely right.
Thank you. I have a vision.
Okay, maybe throwing things isn't the best option. And maybe none of us will start a center for children who can't read good. But perhaps we can still learn from Zoolander's vision. The answer may be found, as Derek Zoolander knows only too well, in the work of social justice. Social justice has classically been thought of in terms of affecting change by providing a disenfranchised or underserved group with access to a service or necessity. Many social justice endeavors dovetail with ameliorating disparity in social determinants of health. Successful social justice interventions would inherently positively impact health outcomes. We might argue that a social justice intervention is a medical intervention, and that the best measurement of the success of a social justice program is an epidemiological measurement. And that is why we can return again to the World Health Organization's report, Closing the Gap in a Generation, in which they argue that traditionally, society has looked to the health sector to deal with its concerns about health and disease. Certainly, maldistribution of healthcare, not delivering care to those who most need it, is one of the social determinants of health. but the high burden of illness responsible for appalling premature loss of life arises in large part because of the conditions in which people are born, grow, live, work, and age. In their turn, poor and unequal living conditions are the consequence of poor social policies and programs, unfair economic arrangements, and bad politics. Action on the social determinants of health must involve the whole government, civil society, and local communities, business, global forum, and international agencies. Policies and programs must embrace all the key sectors of society, not just the health sector. That said, the Minister of Health and supporting ministry are critical to global change. They can champion a social determinants of health approach at the highest level of society. They can demonstrate effectiveness through good practice, and they can support other ministries in creating policies that promote health equity. The World Health Organization, as the global body of health, must do the same on the world stage. And with that, I invite you to take a look at 2 articles that will help us look further into epidemiological research investigating the impact of social determinants on particular patient health outcomes. The first, Material Need Insecurities, Control of Diabetes Mellitus, and the Use of Healthcare Resources, looks at the impact of a few specific need access issues that patients face and how those can impact their control of type 2 diabetes. The second article, Environmental Improvements Brought by Legal Interventions in the Home of Poorly Controlled Inner-City Adult Asthmatic Patients, looks at one specific type of intervention, that of the legal intervention on behalf of patients with asthma to help patients confront housing inequalities that impact their care of their and process of the disease of asthma. For those who are interested, I give you all of the resources used in this video, and I look forward to meeting you soon.